Hello and welcome to the 48th Annual AAKP National Patient Meeting. Transforming American Kidney Health, Patients Take the Lead. My name is Kent Bressler, a retired RN with over 40 years of nursing experience. I am a proud member of the AAKP Board of Directors, AAKP Ambassador, and a member of AAKP's Veterans Health Initiative, and hailing from this great state of Texas. I'm also co-founder of Kidney Solutions, a network of transplant experience, a nonprofit based in Texas that mentors and helps fellow kidney patients find a living kidney donor and supports their journey through the pre- and post-transplant process. Personally, I was diagnosed with FSGS roughly 40 years ago. I am blessed to be a pre-emptive transplant recipient, having 2 days of dialysis prior to receiving my brother Kip's kidney, and that was over 36 years ago. That transplant gave me the chance to prosper with my wife of 53 years, Catherine, complete a successful nursing career, raise 2 bright and successful daughters, and am now looking forward to watching my 4 grandchildren grow up. Being an Army veteran, AAKP board member, and an ambassador has allowed me to participate in the kidney space by representing veterans on kidney initiatives and being involved in Hill Days. As a member of AAKP, I share the message that every kidney patient has the most important voice in determining their care plan. It is imperative that an environment is created that supports kidney disease research and innovations so that we are continually advancing care, improving treatments, and providing solutions for unmet patient needs. And when those interventions and innovations themselves are FDA approved, it's crucial that all patients have access and the right to choose the treatment that is best for them. In consultation with the doctor, they choose the care that's right for them, so every patient can live their best life and achieve their aspirations. And with that, I am pleased to introduce our next session titled Cancer Risks and Kidney Disease. How can novel diagnostics and therapeutics help? As someone who has personally battled cancer, I understand the significance of this topic and am immensely grateful that AAKP has chosen to address it today. I'd like to welcome back to this AAKP event Dr. Christopher Blauser, a clinical professor at the University of Washington. Dr. Blauser's expertise lies in caring for organ transplant recipients and delving into the intricate relationship between the immune system, kidney disease, transplant, and cancer, both pre- and post-organ transplant. Recognize the heightened risks and suboptimal outcomes associated with these conditions, he established an integrated patient-centered research center, the Center for Innovations in Cancer and Transplant, including a national bioregistry, along with a cancer and organ transplant clinic at UW, and Fred Hutch Cancer Center in Seattle, Washington. I'm pleased to share that Dr. Blauser has been a longtime allied partner of AAKP's, having presented on the topic of cancer and kidney disease through various AAKP Healthline webinars and previous national patient meetings. AAKP has also been honored to partner with Dr. Blauser and his team on his inaugural Transplant Oncology Conference held in 2022, as well as the upcoming second annual Transplant Oncology Conference being held virtually on October the 14th. We'll be sharing registration information in AAKP's newsletters and social media channels, but you can also find it in the supplemental resource section of this session. And for that, now I would like to turn it over to you, Dr. Blauser.
Thank you, Kent, and thank you, AAKP, for inviting me to give this talk. I hope it is meaningful, and I welcome any follow-up discussion that may be helpful to any and all of you. I want to talk with you about cancer and the risks related to kidney disease, how novel diagnostics and therapeutics may help. And with that, I want to first share that my disclosures include the following. CUNY Foundation and Washington Cares Foundation. I previously was a consultant and am continuing to be an editorial board member at the American Journal of Transplantation. Our learning objectives include to define the known incidence, mortality, and risks of cancer with chronic kidney disease and end-stage kidney disease, to apply the current cancer screening recommendations, especially in the setting of kidney disease, and to discuss the diagnostic and therapeutic options currently available for cancer treatment in the midst of kidney disease. Our current situation here in the US, like much of the world, is that we're living through an aging population. With that, there are more chronic conditions that people are living with. Because of those chronic conditions, more people are dealing with both cancer and organ failure across the general population. Cancer in the setting of chronic kidney disease and end-stage kidney disease is higher in number, higher in risk in the midst of those chronic conditions and age. And because of the cancer risks being higher in the setting of chronic kidney disease and dialysis, more people after transplant are also developing cancer. We're seeing that more people come to kidney transplant with a history of some type of cancer. And you're seeing here on the left the number of people with a kidney transplant who have had a pre-transplant malignancy rise over the last 16 years or more, along with that percentage rising to now around 8 to 9% of all kidney transplant recipients having a history of pre-transplant cancer. That cancer incidence is different over the course of time when someone lives with chronic kidney disease on into dialysis and then with transplant. And that's something that we've been studying across different populations over the years past. And one of the best registries that has allowed us to study this in a population is in Australia. In 2006, Vajit et al. Published this paper looking at over 28,000 patients. People who were 5 years before starting dialysis had a 16% higher risk of cancer. That risk rose to 35% higher than the general population when on dialysis. When someone then received a kidney transplant, that risk rose a lot more to 327% higher than the general population. So that those risks are definitely increasing with chronic kidney disease to dialysis and then to transplant in ways that we need to know and manage. You'll notice here on the right that many of the cancers that people develop are those of the skin and those related to immune system control. And we'll talk more about that in a little bit. With more cancer, there's also a higher risk of dying specifically because of cancer when on dialysis and with transplant. And that overall risk of death with cancer is about 2.5 to 3-fold higher than the general population. Again, this specific study was published by Eric Au in JASN in 2019 and looked at people on dialysis and after kidney transplant and showed that those on dialysis had a higher risk most of multiple myeloma, testicular or kidney cancer causing death, while in transplant lymphoma and kidney and melanoma caused the most death. Overall, there's a greater than 2.5 times risk of death from cancer compared with the general population based on age and gender or sex in the Australian population. This has been validated across other populations in the world too, and so we know that it's an important component of healthcare while on dialysis and after transplant. The most common cancers in the setting of kidney disease and kidney failure include kidney-specific cancers, bladder cancer, along with prostate. Multiple myeloma and amyloidosis often start in the bone marrow or other marrow-producing parts of the body, and to a lesser extent, but importantly, liver, skin, cervical, and Kaposi sarcoma cancers can develop. The risks of cancer are many, some of which we know, and some of which we need to continue to study. We know that with age, there is an increased risk of cancer. Those who have chronic conditions, like type 2 diabetes, or hypertension, or even kidney disease itself, have a higher risk of cancers. Tobacco use, obesity, and time on dialysis increase the risks of cancer. Those risks are related to decreased ability for the body to repair injury, including to our genetics. The DNA repair is less. Specific viruses lead to cancers, including those I've posted on the right, such as hepatitis B, hepatitis C, human herpes viruses, Epstein-Barr virus, and human papillomavirus. With chronic conditions, along with immunosuppression, people who are dealing with kidney failure have altered immunity, meaning their immune system is less functional. And because of that, there's fewer numbers of cells and functional immune cells to look around the body and do what we call tumor surveillance, looking for tumor signs and then being able to attack tumors. The immune system usually does that. But when there's immunosuppression or a chronic condition like type 2 diabetes or high blood pressure or kidney disease, there's more cells that are not fully functional, or they're just generally less responsive, and that leads to less reaction against viruses and tumors. There's also more cells that regulate an immune response, meaning there's breaks on that normal immune reaction that leads to a lesser anti-tumor response, and all of this then leads to more cancer growth. So as an example of what I'm talking about, I met this man who came to our kidney transplant evaluation clinic when he was 68. He had type 2 diabetes, high blood pressure, and stage 4 chronic kidney disease. He was not yet on dialysis and was hoping to get a kidney transplant before he needed dialysis. Part of our evaluation process, like most of the country, is to do an evaluation of one's abdomen with a CT scan, looking for any anatomic abnormalities that might make transplant less safe. When we did the CT, we found that he actually, unfortunately, had a kidney cancer in his right kidney, as I'm showing you here. It was stage 3A, meaning that it had reached beyond the capsule of the kidney into the tissue around it, and so he needed to undergo removal of that kidney, followed by systemic treatment with a medicine called cabozantinib. Unfortunately, that medicine caused shortness of breath, and so he was evaluated further with a chest, abdomen, and pelvis CT, which showed signs of possible metastatic disease in his lungs. So naturally, this man had questions. He had questions about what treatments, what systemic or whole body treatments he could use to treat this cancer, including whether immunotherapy, meaning using treatments that activate the immune system, would work to attack this kidney cancer for him. He wanted to know whether treatment would impair his existing kidney function and his health, whether it would improve his survival, and if he would be a transplant candidate now or in the future, and if in the future, how long? All of these questions related to his general desires to live well and as long as possible. And I think that's the case for all of us, isn't it? So we come to this crossroads of caring for people who have cancer before transplant or after transplant, along with others who may not have the option of transplant and are trying to live the best on dialysis or with kidney disease as they can. So when we think about managing the risks of cancer, the first thing that I think we can try to do is to engage in our cancer screening as much as possible to identify cancer early and try to prevent it from causing major problems. The general screening population guidelines are to screen for colorectal, breast, cervical, and lung cancer, as you see here, across different age groups with specific tests at certain frequencies. And those are important for all of us, including those of us who have chronic kidney disease. There are certain people who have a higher risk of a specific cancer, and then that would lead to specific cancer screening in that situation. Maybe someone has a family history of a specific skin cancer or kidney cancer, and so they need specific cancer screening to try to capture any cancer early. If someone is diagnosed with human papillomavirus or hepatitis B or C, then they need specific cancer screening independent of the general population screening. Cancer screening is intended to identify cancer before it causes symptoms and then ensure timely treatment, thereby improving outcomes. And that can definitely help with reducing the number of people who are diagnosed with cancer, reducing advanced disease from cancer, and reducing mortality from cancer. Unfortunately, cancer screening brings certain side effects, including anxiety. Unfortunately, more suicide has been associated with cancer screening, and some people are inaccurately diagnosed with a cancer or miss a cancer in the setting of cancer screening. And so that overdiagnosis and overtreatment leads to side effects, and just like underdiagnosis can as well. Because of this, we need to individualize our cancer screening in the setting of kidney disease and kidney failure. We know that chronic illness leads to competing risks of death, meaning other things like heart disease can cause death instead of cancer. Unfortunately, because of the limitations in our system and because of people dealing with other problems, there's a lack of clinical trials for evidence that we should do cancer screening in the setting of kidney failure. That lesser screening, unfortunately, leads people to be diagnosed at a higher stage of cancer when they are diagnosed. And when they are diagnosed, chronic kidney disease or kidney failure leads to higher risk of surgical complications and limited chemotherapy choices. Those limitations have been considered, and because of the competing risks of death from heart disease or infection, and because we want to limit the negative effects of cancer screening, the American Society of Nephrology and the American Board of Internal Medicine have advised not performing routine cancer screening for people on dialysis unless they are going through transplant evaluation. Now, that is something that we still need to consider on a personalized basis. So it's not all people focused or limited in this situation, but I would suggest that you have a conversation with your physician whether cancer screening would be helpful to you. 10 years ago, guidelines were produced to suggest how long someone needs to wait from the time of cancer to a kidney transplant. A lot has changed in the last 10 years, and yet certain elements are similar in understanding. Currently, if someone has an active cancer, they should not receive a kidney transplant because the addition of immunosuppression is going to further suppress normal immune ability to attack that cancer. There are some exceptions, such as those who have small superficial skin cancer or prostate or bladder cancer that can be easily dealt with. While on the other hand, some people have a greater risk of cancer that will persist regardless how long we wait, such as those with significant HPV-associated cancers are likely not going to benefit from a transplant because of the significant risk that that cancer will progress significantly on immunosuppression. Those with HIV probably need to wait longer than their general population counterparts because of how HIV also leads to immune dysfunction. Regardless of the cancer, we should involve the appropriate oncologist and consider the prognosis, meaning how well is someone likely going to do in their current health with a cancer, and then compare that with how well transplant may help. Thankfully, many things have changed. We've had the experience over the last 10 plus years of many advances in cancer treatment. If we look back over time, there's been the addition of radiation and then chemotherapy, and then more recently targeted therapies attacking or focusing on specific molecules in our cells to more precisely treat cancer. And about 10 years ago, immune checkpoint inhibitors were created to activate the immune system and use that attack of the immune system on the cancer to achieve a better outcome. When we think about how we use those treatments and whether someone should receive a transplant or be treated for a cancer, there are multiple factors to consider. In the setting of transplant, that includes patient factors such as quality of life and what we can do to modify their risks, how much immunosuppression we can adjust to diminish their risk of future transplant cancer, other specific cancer risks that we need to address before they receive a transplant, and organ failure associated risks. Can dialysis provide an adequate quality and length of life? There have been some well-done expert opinion-based papers to provide further guidance based on our current cancer treatments that are currently published and available, and we use those on a regular basis. You'll notice as we scroll through that I've provided the current recommendations based on these expert opinions for the most common cancers in the general population that also people live with on dialysis. All of these recommendations are based on expert opinion, and that is unfortunately a limitation to how we can provide precision care for people based on their specific condition. So my goal as we go forward is to personalize medicine based on multiple factors. That includes the cancer type and stage. It also includes biomarkers, current treatments and their off-target effects, comorbidities that people may be experiencing that also impact their health, and fundamentally the patient's health and life goals. As we think about outcomes that people might be living with and how they really see their life, this survey of people who are kidney transplant recipients, I think is a great representation of the common fear of cancer. So these investigators asked kidney transplant recipients if they could trade a certain number of years in order to avoid or diminish the risk of certain potential problems, how many years would they trade? And they asked about cancer and death, cardiovascular disease and diabetes, along with depression and infections. And you'll notice that people were willing to give up over 3 years of kidney transplant function in order to avoid cancer, even more than death or cardiovascular disease. And so it is obvious that we continue to have a significant fear, a healthy fear of cancer, and that's borne out in this survey. I don't have data specifically reflecting on perspectives with chronic kidney disease or dialysis, but I suspect it may be similar. When we think about how to treat cancer, we also need to consider what may be playing a counterforce role, what may be competing against our cancer treatments that might be a problem. Some people who have autoimmune disorders need to be treated with immunosuppression. Oftentimes, similar immunosuppression is used after transplant to prevent rejection of that organ. This immunosuppression treatment is intended to prevent rejection and target specific molecules on the outside of the cell and on the inside of the cell of these immune cells that typically react against an organ transplant or are part of an autoimmune reaction. The most common cell that we try to suppress is the T cell, and the T cell has a major role in driving many immune reactions, including rejection. The T cell also has a major role in identifying cancer and killing it. So if someone has a cancer, the immunotherapy that I mentioned earlier is intended to wake up T cells and specifically have it attack the cancer whenever possible. Unfortunately, that immunotherapy is not as precise yet as we'd like. And so when we use an immune checkpoint inhibitor, it's like cutting the brakes on the car. The engine will continue to rev as fast as we push it without the brakes, and yet the car won't necessarily be steered in the right direction unless we have that steering appropriate. The immunotherapy, like checkpoint inhibitors, will activate the immune system, especially the T cell, to attack whatever's around it, hoping, and for the most part, will effectively attack a tumor, but it will lead to other side effects. Because of that general reaction by the T cells and the immune system, there are potential toxicities when treating with immunotherapy. That can happen across almost any part of the body. The most common areas for there to be a reaction include the skin, the GI tract, like the colon, and to a lesser extent, but importantly, the heart, lungs, and kidneys. That happens 10 to 15% of the time for kidneys, but at the same time it's important to know about and to follow if you need treatment with immunotherapy while dealing with kidney disease. If someone ends up with cancer after an organ transplant and they need to be treated with an immune checkpoint inhibitor because they have advanced cancer and nothing else has worked, that's something that I and other providers with specialty experience have done to help people move towards a cure as much as possible. while understanding that activating those T cells is going in direct contraindication to the rejection process that we're trying to prevent. What that means is that people are at about 50% risk of rejection in the course of the first 8 weeks after starting treatment. In this study that I helped lead, we found that rejection risk after starting checkpoint inhibitor was between 35 and 50% of the time within 2 months. So anybody who needs to start this type of treatment should be prepared early. What can we do to follow treatment of cancer and understand whether or not our treatment is effective? Now we have another tool in our toolbox, and that's the use of cell-free DNA. This idea has been around actually for many years, first discovered in 1948, and it identifies the breakage of DNA from a cell. Sometimes each of our cells release DNA when it either dies or is breaking off into different parts. And when that happens, little bits of DNA float through the bloodstream. They're around for 30 to 90 minutes in general, but that's long enough for us to measure it. And that's now been used looking for any abnormalities during pregnancy. It also is being used now in the setting of tumor surveillance, meaning that once we have a tumor that someone has been diagnosed with, we can then identify specific DNA from the tumor that is different than the person, and then use that test to follow over time blood samples to see if there's DNA from the tumor that might be decreasing in percent with treatment, or if increasing, telling us that the treatment is not effective. Separately, we're using it in the setting of transplant to identify donor-derived cell-free DNA as a potential sign of injury and possible rejection. So, as an example of that, donor-derived cell-free DNA is something that I use for some of my patients when we're watching for rejection in the first year, or when I have concerns for rejection over time. And so, using a blood sample, we can identify enough of a difference in between the donor and the recipient DNA to potentially identify injury, and that often would lead me to do a biopsy of the kidney to see if there is rejection. In the setting of cancer, like I mentioned earlier, now there are multiple types of assays looking for DNA from the tumor that is different than the person, and those tests are being created for different body fluids or different areas that give us the ability to follow over time. There are uses of this in the cerebral spinal fluid, in the lung fluid, in abdominal fluid called ascites, even in the stool at times. But the most effective has been in the blood, where if someone has a tumor already identified and then the test is created specifically from their tumor to look for DNA that's from that tumor different than self, one can then follow whether the treatment after the tumor is first seen is effective. So as we think forward, there's the need to adjust our use of medicines for someone's chronic conditions to enable a cancer response. And in the setting of transplant or immunosuppression for autoimmune disease, different levels of immunosuppression will need to be used to both help a cancer be treated appropriately while also maintaining management of the transplant or the autoimmune disorder. Different cancers need different amounts of immune system control. You'll notice on the left side that breast, thyroid, and prostate cancer don't have that much immune reaction, and so I don't typically adjust the immunosuppression too much. While on the other hand, if someone has advanced squamous cell carcinoma, melanoma, or kidney, or lymphoma cancer, oftentimes I'll stop the immunosuppression when someone is started on systemic cancer therapy. Those in the middle, I will adjust somewhat, but not necessarily as much. If someone is treated with an immune checkpoint inhibitor, you'll see that there's need to stop the mycophenolate or azathioprine, adjust the dosing of tacrolimus or sirolimus, use some steroids to help prevent inflammation, while potentially using a diagnostic test such as circulating tumor DNA to follow for the treatment of the cancer, and being aware that there may need to be dialysis to care for someone who has kidney disease or other conservative care options. As we think about cancer in the setting of kidney disease, we know that people have a higher burden of symptoms often with more pain, often because of the kidney disease, metabolism of drugs is altered, including for narcotics. And unfortunately, this leads people to have a shorter survival than they otherwise would. Because of all of this, I strongly encourage people to engage with palliative care, a team that can help improve quality of life and even length of life, compared with not having them around to help us. In the midst of all of these needs and unanswered questions, I established the Center for Innovations in Cancer and Transplant 2 years ago to lead a national bioregistry of people who have cancer before and after organ transplant. And that registry enables us to do 3 dimensions of research: patient-reported outcomes research, epidemiologic research, and translational research. Related to our registry and our center, I also established the first of its kind multidisciplinary consult clinic for people who have cancer while being organ transplant candidates or recipients. And we often address questions such as when someone can proceed to an organ transplant in the setting of cancer, what the optimal treatments are to get them there, as well for people who already have an organ transplant, what the optimal cancer therapies are to help them thrive and maintain their transplant function as much as possible. So as you see in this overlapping thread, our work is intended to address 3 dimensions of research: epidemiology, patient-reported outcomes, and translational research, all with the bioregistry, and studying with that specific immunotherapies that are most effective for many cancers while can have side effects and risks for our patients. Better understanding those risks and minimizing those risks to optimize outcomes is our goal. And complement therapies are another area that we study specifically related to cancers and organ transplant. This is the team I have a great opportunity to lead and work with on different projects, and I welcome the opportunity to discuss our work if you have any questions. So in summary, we know that people who have kidney disease have a 1.5 to 4 times higher risk of cancer. Many of those cancers include kidney, bladder, skin, and thyroid. The cancer screening should be individualized, but applying general population guidelines in addition to any high-risk condition. We should understand the prognosis for the specific cancer someone is living with, along with waiting times if they are hoping to get a kidney transplant, and incorporate that into their care. Circulating tumor DNA and immunotherapies for treatment of cancer can be considered. Right now there's limited data, and I hope that I and others I'm partnering with can help fill that void. And finally, partnering with oncology and palliative care can help improve quality of life and length of life when dealing with this combination of cancer and kidney disease. My overall goal every time I meet someone is to personalize my care to optimize someone's health and life goals, integrating these components that we discussed earlier. I want to thank everybody who's participated in this conference and welcome any contact that you may want. You're welcome to reach me by my email, chrisbl@uw.edu. I want to thank you as patients, along with the nurse coordinators, the administrative professionals, the teams I get to work with here at the Fred Hutch and the University of Washington, and around the country and world as we continue to work to help improve everybody's life. Thank you so much.
Thank you, Dr. Blauser, for sharing information about the important work you are doing regarding kidney disease and cancer. Your compassion is evident in your work, and I wish you nothing but success in your research. You can count on AAKP to support you along the way.